it plugged in.
So good morning, everyone. My name is Michael Fernandez. I'm with Script Hesco, an equipment vendor. And so pretty much everything that you see in this office is stuff that our company carries, like 65,000 products, everything to do chiropractic. And today we are going to have a training on this nice little tool, but I'm going to pull this table out so somebody could just lift up those wheel chocks on that side. I think if I wheel it out, it'll be a lot more ergonomic. There we go. That should be good. Simple table adjustment. This is for patient comfort, getting on and off, as well as for setting the correct angle height of pull. You'll notice on the side of this rope exit, there's gradations, 10 degrees, 20 degrees, 30 degrees. Depending on what segment you're targeting, there will be a different angle for L1 versus L3 versus L5. Does that make sense? No.
It's your fault for sitting there, Tasha. It's your fault for sitting there.
I know, I was.
So does anyone want to come around on this side so we can all see the screen? And is there anyone else that I'm waiting for?
I just continue going. Anybody else is late is their problem.
Perfect. In terms of roles and responsibilities, who would be responsible for setting people up on this unit, or kind of everyone in the room?
Most of us be the vortex, so we, what, 4 of us, or
Okay.
three of us are
1, 2, 3, 4. Okay. Awesome. Well, so if we can come around and take a look at this screen. Here's your standard screen. Actually, even before so let's go over the screen protocols and we'll go over patient setup. First thing you want to notice is that the rope doesn't come out. You have to press and hold something called rope release, and it comes out. You let it go, the rope is stuck. Never hit that button with this thing dangling, because it'll come flying back and break the screen. Got it? Oh, dang, yeah. So keep one finger on it, hit this, let it back in. Everybody's happy. Remember that? Okay, good. You've got 2 basic protocols, cervical and lumbar. I'm going to say 90% of your patients are going to be lumbar, plus or minus?
I feel like it's 50-50.
Yeah,
Really?
it's 50-50, yeah.
Oh, wow. Then I should talk to him about another tool that he could just lay down there for a fraction of what this thing costs, and all it does is cervical traction. It's a cute little device. Yeah. If you wanted to use this tiny screen as patient education, you could. It goes over what cervical protocols are, disc involvement in muscle guarding, etc. However, I don't actually know any doctors that click this. This is more like marketing fluff that this company can put on their cute head to give them competitive differentiation against the dial units. Does that make sense?
Sure.
Okay, so we're going to hit lumbar traction. Once again, this is patient education. Traction rationale gives a verbal explanation. I have no idea why they would put this on this screen, because you can't email it to somebody, you can't get it to their phone. It's just there. So that part of training takes 30 seconds and we're done with it. What you do want to hit is edit, because from the edit screen, here's how you're going to adjust your treatment parameters. How many steps is the rope going to pull that patient before they get to the therapeutic treatment level? How long does the treatment interval last? How far down do we go in terms of minimum pull? So we got maximum pull, minimum pull. What's the slope of the line to go up? So do you drop them fast? Do you come back up? The cool thing about this machine, this is the advanced one, it has 3 rope speeds. So here you see speed 30%, speed 50%, speed 100%. So 30% are for your acute patients. They'll walk in all antalgic, and everything they do is slow and guarded, and they can barely move. Low and slow. Start them off on and I'll send you guys a separate document for clinical protocols that, obviously this is stuff that the docs would prescribe, and then the techs would actuate on the unit. So A low rope speed is for your acute patients, a medium rope speed is for your subacute patients, and you can use a fast rope speed for chronic patients, people who've had the condition for years, they've already adapted to it. And also, as the treatments progress, a typical decompression treatment, not time frame, but iterations are anywhere between 20 and 25. So after 5 or 6 or 7, you might be able to start increasing rope speed as their tolerance increases, as their posture benefits, as their overall condition gets better. So let's just go back to a medium rope speed. Make sure you check the rope speed, because if the last patient was chronic and now you got somebody acute and you don't do that, it's gonna pull them and they're not gonna have a super great experience. So these are just things to check for, you know, basic liability stuff. If you want to edit the max min levels, here's where you put the max level, min level. There's several schools of thought when it comes to how many pounds of pull. The old school methodology was 50% of body weight. That's gone down to about 25 or 30%, especially on your first couple sessions. You might tell them, and this is something to discuss with Dr. Gary, give them a session on the house just to see how their body reacts to it, so that they don't feel like they're paying for something that they may not get full benefit from. You want to do half of what you think that patient needs, just to see whether or not they have an adverse reaction, or what we call decompression hangover, where the next day they're slightly worse than they were beforehand. So I know clinics that will do 1 or 2 sessions for free, and then your treatment protocol starts, because by the end of the second session, they're like, okay, I totally see the value in this, I want to sign up, and then they sign up, you know, for the longer treatment plan. Yes, so you can do the mathematical calculation in your head. If somebody's 257 pounds, you can multiply that by 20%, pull out your iPhone or whatever. So you can do a physical number, like max level, I'm just going to put in 50 pounds, enter. Min level, 25 pounds, enter. Or if you want to do it as a percentage of body weight, if you look over here, you can do, this is called entry method for force levels. You can do actual poundage, or you can do percentage of body weight. So if you put body weight here of 200, let's do 67 pounds, which is a strange number. It's not really a strange number, but it's not easily dividable by 0.25. And then their max level is expressed as a percentage of body weight. So if you want to do 30% of body weight, you hit 30, enter. And voila, it tells you that 80 pounds, here it's in the grayed out area, is 30% of their max body weight. And their min, what percentage do you want? From 30%, do you want 10%? So just understand.
And then the protocols are giving us, telling us the percentages that we should be
Correct,
using.
correct. And I can even schedule you, Dr. Chris Prue works for Chattanooga. His sole responsibility is to get the hundreds of clinics around the country that use this. I mean, this is the most popular machine by far, like by far. Every VA hospital, every whatnot has this unit in there. So it's pretty popular, and it makes it interoperable, gives you skills that are, you know, portable. That being said, he has a weekly seminars and webinars where he goes over the rationale behind the protocols, why you would use certain things for certain people, how many sessions you would use, when you would ramp them up. Are they coming in acute? Are they coming in chronic? Do they have discogenic lesions or movement pattern, aberrant movement patterns that will also cause disc type issues, but it may not truly be disc. Things where you want to kind of pump the disc so you can put it on a very low hold time, so it pumps, relaxes, and then this way you can get some fluid back in the disc. So does everyone understand absolute numbers and then relative percentage of body weight? And you would hit this little button up here.
Those are 5-pound increments, right?
1 pound increments.
Oh, great, okay.
So if I want to do 81 pounds, 81, enter. Now I've got 81 pounds.
Beautiful.
So you can do it And the reason why is for cervical, there's a big difference between 18 pounds and 20 pounds. Does that make sense?
I'm still trying to understand, like, for this absolute one, so you're putting in how much they actually weigh here?
No, no, no.
Or, okay.
So,
I get you doing
the,
on that one.
on the right side, if you subscribe to the school of thought that pull poundage should be a percentage of body weight, okay? Then you would put in their body weight here, and you would put in what your philosophical percentage is. All of my patients, I'm gonna pull at 40%, because I've been doing this 20 years, and I've talked to doctors that way, or, you know, from the 80s. 50% of body weight, sine qua non, that's the way it's gonna be. Okay, punch it in. And 25. Now what's gonna happen is some of these patients are gonna go through decompression hangover. It's like, oh God, that was a strong pull. So it's better off, like I said, if you can do a few pulls gratis. This way they don't feel like they're paying for something that wasn't efficacious. Look, all we're doing today is seeing how your body responds. You should feel better. You may feel nothing, but I'd rather have that happen than you walk out of here worse. Does that make sense, Mrs. Jones?
That
Yeah,
does.
of course. And now you get their buy-in, and they realize that you're being reasonable. If you subscribe to the theory that no matter how much somebody weighs, we're gonna start them off at 35 pounds,